are going to be starting the afternoon session with a fireside chat. And this topic is going to tackle navigating trends in ortho. What is on the horizon? We'll be looking at emerging technologies and regenerative medicine, all of which are revolutionizing how orthopedic care is delivered. Now, our speakers will also touch on the challenges of making these advancements accessible to all. So please welcoming back to the stage two gentlemen, Dr. Fahad Attar and Dr. Omar Musa.
Hello, everyone. Thanks for being here. Omar, do you want to start off, or?
Thank you, everyone. Of course. First of all, my name is Dr. Omar Musa. I was born in Egypt, raised in Amsterdam, got my MD from Amsterdam, and then just 1 year ago, I moved to Boston, MGH of Harvard, where now I'm currently doing my PhD in focusing on the reconstructive surgery in a holistic approach. Please.
Hi, I'm Fahad Attar, orthopedic surgeon by profession, and also CEO and co-founder of We Healthify, and CEO and co-founder of Regenesis Orthobiologics. So we concentrate on regenerative orthopedics and precision health provision, and we're currently set up in the UK, and we're looking to expand to the Middle East and the GCC. Thank you.
So what we wanted to do today is actually make it a little bit more engaging, since of course it's the last day and everyone wants to enjoy everything of this last part of this wonderful conference. So we would like to encourage everyone that's here to actually ask any questions or that has any notes to come up to the microphone in between our session to make it a little bit more dynamic for everyone and to keep it in a more comprehensive perspective with all of your experiences and insights, and hopefully make this as fun as possible. So what we wanted to do, Fahad, we wanted not to specialize and go into the weeds with everything that we focus on in orthopedics. What we wanted to do together is actually bring it a little bit more alive by bringing other insights to our specialization while we go through the process of the caregiving pathway. So that would mean we start with everyone that also does screening or also does something in predictive models, go through diagnostics, whatever any comments or insights people have can of course add, and then end with not only treatment but also the part of like the vision on the horizon and where we want to go with not only orthopedics but also with the caregiving professions that you guys would hope to share with us. If that sounds okay?
Yeah, I think that sounds like a good plan. And just to reiterate as well, anything as we're going through, if someone has any questions, just get onto the mic or raise your hand, and we can have sort of a lively interaction as we go along. I think that'll be good.
Perfect. So I was looking forward for a long time for this. You have so much experience and so many things that we can all learn from. Please, could you tell us something about the first stage when someone comes, or even before they come? What is your current practice doing for them, and how are you seeing it evolving?
Sure, it's an interesting question and a very broad one. So I'll sort of break that down into what we used to do and how it's changed to what we're doing or what we're recommending clinicians and physicians to sort of do. I think a lot of the time, most people get focused on the disease and on the condition. And every time a patient walks into clinic, either to see us or any other physician for that matter, you get very tunnel visioned on what you're trying to achieve, what you're trying to treat. And although you've probably got a lot of experience and a background in treating and approaching that, you tend to focus only on that aspect, just the one aspect. But I think what has changed now is when we actually see people coming in, we know they've got a specific complaint, specific condition, specific problem they're coming in with, but we tend to sort of look at a little bit more of the broader picture. So we've got some treatment options that we know will help that specific problem, but what we actually do as well is to try and realize that There's lots of different facets that are contributing to that problem, and there's a lot of different modalities of treatment that'll help what we're trying to address and what we're trying to achieve. So from that perspective, we don't just look at the problem now. What we actually do is look at the patient as a whole. So they get seen by the specialist, they get seen by a nutritionist, they get seen by the physio, they get a full analytics done on their initial investigations, they have a genetic screening program, they've got a biological age test done. And all this information that we gather from all these different areas helps us streamline a personalized plan for that patient. Because if we just concentrate on one disease, one condition that they walk in with, you may be able to get them 70% there, but you're losing out that 30% of the periphery that you're really concentrating and you need. So now with this approach, what we're recommending is we can look at a full 360-degree view of the patient, what's missing, what's lacking, what they need, what we need to supplement, how we're going to address them, what personnel we need, what MDT approach we need, and we sort of tie all that together. So at the end of the day, what we're doing is working with like-minded clinicians, like-minded specialists in various different facets and modalities to help the patient.
That sounds great, because what is happening in the same time from a care provider as a physician's standpoint, what we're trying to do, and we've been trying to do that for ages, is see a patient in a holistic, comprehensive approach. The thing is that normally it would take so long and it would take so many different facets to first go through before you can actually go and assess the patient themselves in clinic. But before COVID, and we talked through over that this morning, before COVID, that just didn't seem feasible. It was something that wasn't possible actually in this world, where we have gone through a digitizing kind of revolution, and now all these things are possible just by everyone getting acquainted by it, getting tests done before they actually see a doctor and everything beyond that. So at this point, how I also see it is we are all are having the tools that we can actually use to go through a very efficient and effective kind of way, using that 360 approach and all that data that comes with it, streamline it just like you said in a funnel, which all could take 5 minutes. And that is thing where, of course, we are enabled now by things in great digital revolution, where Niels there would like to ask a question because he knows way more about this than me. Can we get a microphone, please?
Test, test. Yeah, okay. Thank you. I was actually wondering, you talk about a 360-degree view on the patient's life. Are there any certified or tested models that you guys use to get the same conversation going with every new patient? Or is it more like a way of feeling how the conversation with the patient is going and then adapting to what they're explaining?
So that's a good question. And I think every time a patient comes in, what we're now training our staff and all our sort of receptionists and even secretaries now is to try and do a generic screening form where they don't just get asked about an initial problem that they're presenting with, but they get asked a few questions about, not detailed history, but a few questions about various different aspects of their health, what they're doing, health status, their height, weight, BMI, because that then starts putting in our mind a program for them who they at least need to see. So we have about 3 or 4 touch points for them then when they come in to see the relevant people based on the initial questionnaire. Now, based on those initial investigations or initial consultations that they have, we may realize that there may be 1 or 2 more things that we need to do or 2 more tests we need to do, and then we that sort of tie that in. The other thing we try and do is have a in-house all services incorporated sort of setup, because what we don't want is to people to keep coming in and out, going to 10 different places to get the same thing done. So we're working very hard with and collaborating with various different sort of specialties and clinicians to have an in-house service. So when we know that these patients are coming in, we have those facilities available in-house. So they come in, they spend about 2 hours, get seen, get the investigations done, get the tests done, and then they go. And then they come back for a follow-up again when we have all the results and reports and a personalized plan for them. Just to sort of expand that question is, if we've got sort of a protocol set which is more globally followed? Answer to that is no, because I think this is still in its infancy. And I think a lot more people trying to get into this approach and trying to do some studies and data publishing will help that. So at least you get some sort of generic pathways, and you think if they're coming with this condition, these are the barrage of consultations and tests you need, and with these results, these are the investigations you need. So at the moment, we're not yet reached that stage from lots of sort of sectors, and even I speak to my colleagues in the US who are in this sort of regenerative field, and everyone seems to be doing something from their own perspective. But I think the focus is to try and get a general sort of provision, if you like, from a diagnostic perspective and treatment perspective for certain patients, and profiling certain patients and also conditions.
Yeah, exactly. And in the Netherlands, we've just started to use the model of Machteld Hubert, which we've also talked about in our presentation. And it kind of enlightens, I believe, 6 dimensions within a patient's health. And it helps clinicians like yourself focus on certain areas within the patient's like complete being, so to say. But it's good to hear that you're working on that.
Let me go into depth exactly what you're talking about in US, how we use this in my current practice in the US. In MGH in Boston, I'm working in a kind of multidisciplinary team that is called the Interdisciplinary Network of MPTs, where we have a specified multidisciplinary team who has every team member that should be in there for all the lower extremity kind of patients. When a patient comes in before any consultation, assessment, whatever has been done, they go through all the specified team members, and they all just put in their part based on the Huberman or like Huber dimensions that were before of the WHO. And it was actually published, I think, in 2011. It was like way before, but until now, it's a miracle that a lot of people are still not putting it into practice. Where a lot of other places are, of course, I'm very proud of the Netherlands doing so. But at the same time, we should be collaborating more. While, of course, WHO should be one of the top leading organizations leading this, we are actually focused, and my thesis currently is focused on setting more benchmarks like these, more criteria to actually first define what we're doing in our centers, then make that more universal to the other similar centers, which is also like through survey studies that I'm doing and all those other things, then set some benchmarks nationally, go internationally back to Amsterdam for my instance, and then also with, of course, all these centers there to have one general universal definition, benchmark, where we can all put our great minds together and think about the best possible outcomes that we should collect, but also see how we actually should put our interventions for those specified kind of problems these people have. And at that moment, we can also even try to translate it to the less abundant kind of places where you can try to translate the models that you create to more socially vulnerable patients. So we're also doing a lot of studies where the insurance is not the greatest in the US, and people have more social vulnerability, which can be objectified in different measures like the area deprivation index, for instance. And when you can take those kind of models, you can actually try to put that in a very less or a high, low socioeconomic system and make the best effective use of those cost savings that you had from higher uptakes in those places and the same models for the lower ones. And eventually, hopefully, put the models in like the right places over the whole world. But we wouldn't go to like the horizon kind of ideas yet. Thank you for your input.
Yeah,
Oh,
sorry,
no, thank you both
just
for
to
the
add to
answer.
that, I think one of the other problems or the hindrance is cost and accessibility. So even though you've got a good model in place, is trying to put it all together is expensive. And how accessible is it for people from a clinician perspective, specialist perspective, and also from an equipment and service line perspective? So I think that's one of the hindrances when I speak to a lot of people. That's one thing they always come across, say, yeah, we want to do it, but these are the sort of stumbling blocks
Yeah.
or roadblocks that we come across.
Yeah,
Exactly.
and there's the problem of scalability, because for a few people who are maybe somewhat more wealthy, this shouldn't be a problem. But to enroll it across a mass of people that don't have the funds, then it becomes very difficult to have an
Yes.
MDO multidisciplinary
Yeah.
team available for those patients.
Yeah.
So then you need to rely, I think, more on what the patient itself can do. But very interesting your answers.
Yeah.
Thank you.
Thanks.
Thank you. And not only that, to add upon that, the thing that we should also do is take a very good control of what we're actually doing with AI at this moment. Everyone's talking about it, everyone is using it, but we're not really talking about the injection of data. What are we training our models with right now? Everyone's just individualistically talking to it, using it to their own needs. But what we also should be really careful with are all the specific lower socioeconomic status people who are not having their data assessed, and it's eventually creating a very major bias in our models and what we're doing. So I think one of the main things we should be doing is also trying to find those specific needs for these patients and try to get that data from a beginning, or even make it universal from a very starting beginning, to actually try to mitigate that risk of bias. We'll never remove it like any bias, but at the same time, we should be very aware of it, because at this point, it could be a very great disaster if we're just trying to see patterns in things where we've only been imputing it with the 10% that is wealthy in this world.
Yeah, I agree actually, because I think data really is king, but you need a good spectrum of data from various different populations and sphere. So obviously, like I said, if we can train them, then you can predict a lot better with overall global data at different levels of social strata rather than just the upper levels, because then it just becomes a service and a provision for the wealthy, which it cannot really translate down to people who need it really.
Exactly. Can you tell me and us a little bit more about how you're currently integrating that in your practice?
So at the moment, what we are doing is collecting obviously a lot of investigative data from patients who come in.
Yeah.
And we obviously have models being made either from the companies we're collaborating with who've already got preset databases that we use. And we try and use them at the moment to try and fine tune predictive modeling. So we try and do something like, if patients come in with this condition, with these risk factors, and having this procedure, what are the success rates? What are the disadvantages? What are the risks? How long they're going to stay in hospital? What are the recovery patterns are going to be like? So most of that can be forecasted to a certain degree with the data sets we've already got in place. So we're using that just to give us an indication and to give the patient an indication, to sort of empower them to at least know we've got this information, from us, sort of thing. Now, going forward, what we tend to do is obviously as these get built up and everyone is doing it around the world, you can collaborate them and you can share data, which I think is going to be the strength with these models. And when you have that scenario where you've got a lot more data that you're sharing, and you've got a lot more data from various different social strata that is being inputted into it to train your model, you get more specific, you get more refined in what information comes out and how you're going to use that information. So that's what our focus is at the moment, is to slowly build and obviously collaborate with like-minded centers, like-minded hospitals who are doing similar sort of things. So we try and get a better, broader perspective.
I think the right word to say that is building systems, or the right way. And that is great to hear. Exactly what we're doing right now in my research is setting those benchmarks, also seeing how we can collaborate more by seeing the different perspectives, but also from different populations, how the differences actually align, and how we can see the discrepancies, but also see things like risk factors. So everyone's talking about, of course, predicting, but even as we all know, in research before AI, we've been building creative and very nice predictive models. Now you can't, of course, call logistic regressions as an AI model, but some people are trying to do that these days. Where at this point, we just have to be really careful about how we're using which tools, and actually be more conscious about what the fastest way is to get to the place where we need to be and not just throw AI to it, but just think about it first. Do we have to sit together, put different perspectives in first, have some kind of institute before we collect data? Or what everyone now is doing, just collecting data and then not really looking on their shoulder, like to their side, and then eventually, of course, getting surprised. Oh no, you're doing something else than I am. Oh no.
Yeah, just to add to that, I think that's important because yeah, everyone's collecting data, but I think you need to do it, as you said, try and get to a place quicker, but I think also safer.
For sure.
So we need to be there quickly and safely, and each country and each healthcare system has got its own regulations and directives. So again, it's important to make sure that you're aligned from that perspective. But I think at the moment, probably what's happening is a lot of people are collecting a lot of data sets, a lot of data points, a lot of touch points from patients. But what do you do with that data, and how do you process it, and how do you get it out into a format that's going to be understandable to the clinician, to the patient, to the health facility?
Exactly.
And how are you going to add value? Because all systems now are moving towards value-based healthcare. Now, value clinically wise for the patient, and value from a monetary perspective for the healthcare sphere and healthcare sector and clinics and hospitals. So for a win-win situation, I think you need to have some sort of a regulatory system that when you're collecting the data, what is going to help? Because some of it you may not need, and some of it will be very, very important.
Exactly.
So you need like systems in place that will track that and that will fine-tune that system. At the moment, I don't think there is. And I think that may be one thing to sort of develop and work on as we go forward.
Exactly. I would actually want to bring up a just recently published paper in JAMA, just last month or a couple of months. It was actually assessed how the efficacy is for a AI without doctors and an AI controlled by a doctor. And what we see is that the difference is actually not superior for the doctor reasoned control group, where it is actually defined now or clarified for that the doctors don't know how to use AI properly. We are not prompting it in the right way because eventually it's just a weapon. It's two-sided, right? Where when you look back at Japan and you see all those nice samurai swords that we see in movies, you need proper technique to use that sword in an effective way. And that is exactly where we stand now, where everyone is getting like a very nice, sharp blade and is just like swinging it against trees, where eventually we need to learn first how to handle it so that we don't cut ourselves. And that is something that's not, I think, at this point very aware or universally understood, where we should try to get more in these steps in the future. But just with my eye on the time, we should, I think, go on to the next treatment decision making kind of chapter. Is there anyone in the room right now that has any comment or questions that we should speak of? No. Okay. Then going into, I think, the treatment part with also looking towards the future. How are you envisioning what we're currently doing in decision making and also what we're going to do or should do if we would have done everything that we just spoke of the right way and we can move forward?
So I think decision making involves a lot of different sort of facets. One is obviously information gathering and investigations, which we will have that information from, and using that information to basically make patient-specific plans. Because I think the way now is going towards is personalized health, personalized treatments, patient management plans that are specific for the patient, the condition, their background health factors in place. So I think the decision making is going to go more and more in that direction. And I think that is the best way, because I think you do need to involve various different aspects of a patient's health for an overall progress. And this other big sort of buzzword at the moment is longevity, which everyone is trying to sort of, push and say we need all of this. But I look at it more than longevity is more healthy aging. I think healthy aging is probably a better word to use. And once you've seen a patient who's come in and who's had that initial problem sorted out, I think optimizing their health based on other small areas that you've picked up will help that journey towards healthy aging. So you don't just close that chapter there saying, we've sorted you now, off you go. Because there's a few other things that you've picked up. So that's why personalizing the healthcare plans for patients, moving them across this sort of journey for a more holistic way, from a more personalized way, with a healthy sort of aging way, I think is the way forward. And I think that's what is going to be the next focus going ahead.
Putting it in more practical perspective again from clinic, I've been working before with a lot of reconstructive patients, so also burn patients with a lot of trauma, not only physically but also mentally, with sometimes also social vulnerability. And what you see is that you really need a very good, trained, and efficient kind of multidisciplinary team looking at them. What I think will happen also with the decision making and also following these patients in the future, hopefully, when we have the right data set and we can actually screen the right patients out of those patients and getting like more of a 6 dimension idea or profile, as you may call it, of every patient, you can actually adapt the team towards their specific needs. Where currently it's more done in like physician kind of feeling that someone might need something, but we're currently also under a lot of strain where we're all biased. So I would personally believe that if we would have the data making those dimensions for us, the models, we can actually adapt the team, maybe even by automation, making our schedules or whatever, and then we can actually do whatever we want to do with the patient to make them feel better or more or increasing their longevity in the long term. And what I think will happen is hopefully when everyone has this right profile on their phone or anywhere they go, is there whenever you or your body actually needs the specific care you have. Let's just say you went through an injury and after you've been helped and treated in a hospital for all your biological kind of problems, you will still have this overcoming moment of mental stress and mental burden that comes after it. And at that point, when you're home and you think you should be healthy and not feel sorry for yourself, not many people will go to a doctor. Where at that point, these systems can actually signal it for the right patients that actually need it and just say, okay, his heart rate increases, which could be aligned with, I don't know, post traumatic stress disorder. So go back to the doctor just for this specific patient, not 20.
Yeah, I agree with that. I think most of the drive forward will be based on outcomes, and you need to be able to gather these outcomes from patients because, yeah, they'll get over that specific injury treatment and they will have their outcome scores sent across. But if you can monitor them as they go along, you can pick up problems beforehand,
Exactly.
preempt them,
Yeah.
and intervene. So if they've got like scoring systems in place and outcome scoring systems in place that can do that for you, they can even prompt, like I said, on an app or something like that to say, I think, you need to go see a doctor. This is the time to go and make an appointment. And I think that will help. And again, that's very personalized to the patient, personalized to them and their situation, which again is important.
Yes. And also, if anyone wants to ask any questions, please feel encouraged to come to the microphone again.
It feels like I'm part of the discussion now, but no, what we see is that a lot of nations still pay doctors by the production that they do and not per se the outcome that they realize. So, for instance, you get reimbursed by placing a new knee without checking if the patient can actually walk further than he could before. Is that something that you guys take into consideration when you reach out for the outcomes, like you just said, Dr. Fahad?
Yeah, I think that's important actually because outcomes is completely different and you got to make them more objective and make them more validated. Because when a patient comes in following a procedure, let's say a hip replacement they've had done, you look at the x-ray and we say x-rays look great, x-rays look fine. You turn around to the patient and say everything is fine, off you go. With the patient, yeah, I'm still complaining of a little pain, I'm uncomfortable. But you say, well, the x-rays are fine. I think it'll be okay, and off you go. So that's not really objective, and it's not really caught that patient episode properly. So I think if the patient walks in and has done an outcome score to question and say, right, I'm finding difficulty going up and down stairs. This is my score for that. I'm having difficulty getting up from a sitting position. And they're looking at a graph which shows their outcome 6 weeks, 3 months, 1 year. And the clinician can see that and the patient can see that. You can make a more of a conversation with the patient to say, right, yeah, you were doing well for the first 3 months. Now you've dipped. So what has changed? What is different? They'll say, oh, I stopped going to physio. You'll go, okay, so that's
There
the
we go.
problem now. So let's readdress that. So it makes it a little bit more objective, and it also gives the patient the satisfaction that they can track their progress as well. So I think outcomes is very important. And I think the more and more people start using outcomes for decision making, joint decision making with the patient is valuable.
And then, can I add one triggering question? Are you willing to make a cut in the pay that you receive if the outcome is not what we had hoped for?
I think you should be. What's value-based healthcare? Value-based healthcare is you get paid for your outcomes. So which means if your outcomes are not where they should be, you shouldn't be paid for that service, or the department shouldn't be paid for that service. It's a bit harsh, singling out a consultant or a physician to, for that.
I didn't mean you specifically.
I hope not. No, but I see what you mean, and I think it should be. It should be value-based driven. So what they say is, if your outcomes are very good, then you will have a supplementary benefit because obviously what you guys are doing in this department is great and is shown by your outcomes. Because till that happens, we don't know. And also tracking financials to the outcomes is important to say, right, okay, so if you're spending so much money and these are your outcomes, what is the value you've added based on these outcomes? And that's a very important conversation, especially at hospital clinic management levels, because they've got to make a decision on what services they want to continue, what they want to stop, how they want to change, how they want to divert funds. So if you haven't got outcomes and if you haven't got quantitative data to say what you're doing is adding value and what you're doing is saving money, then it's a very difficult conversation to have.
And I think that actually circles back to exactly what we were talking about before. I know I'm beating it over that horse here, but it's all about benchmarking and setting the universal criteria first, because the PROMs, the patient reported outcome measures that Dr. Fahad is talking about, right now, currently, when we're talking about the reconstructive patients that I'm working with, we have, I think, maybe 15 PROMs, different kind of outcome measures that we're all trying to use. And every center is using different ones. So what I am currently trying to do is unify that to all using the same ones. And that is just a baby step in starting to do it all on a national level, and then taking it again, bridging over the gaps towards other places where eventually, hopefully, we can gather all those outcome measures and then start to think about systems where we can use the outcome measures again to make a better place for everyone and help the patients that actually need it most. So to close it off, I would like to make a call to all care providers to also look to their side, to the other people around them, to see what their vision is, what they are using, and hopefully just throw a ball in the air and make some kind of connection to think about what we should use together as a system so we can all step forward in the right lane together as the system that we are, of course, as human beings. Thank you for your time.
Thank you very much, everyone. Thanks, man.